Thanks. Good evening, everybody. My name's David Wright. I'm the Chief Executive of United Kingdom Digital Health and Care, and I'm also one of the directors. This evening's topic, we're going to be looking at medical records. Who owns them? We've all got our own personal view on this. We've all got a personal take on who should use our medical records. So we're going to explore this in a bit of details. We've got some attendees to the webinar from all over the world. It's fantastic. And also some very local people that I can recognize. Great to have you on board, Roger, Attila, etc. Mark, we've met before. It's wonderful to have you on board. Jose as well. So let's take it away. My name's David Wright. I'm an ex-CEO of the Royal College of GPs in Australia. I've been in the UK for about 2 years. I was involved in a lot of the medical records issues in Australia, mainly to do with my health record, which is very much a patient-held record. But that had its own problems, and I'm now exploring what's happening in the UK and the NHS and so on, and there's lots happening. I'd like to introduce first Angus Wallace, who's the chair of UKDHC. Angus, if you'd like to introduce yourself, and I know you've got a presentation to take us away.
Thank you, David. It's an honor to come and talk to you all about who owns your medical records. And I'm going to start straight away with my presentation.
As Angus is just getting that ready, I'd like to encourage you to, we're going to have a Q&A session. We're going to be asking some tough questions, sharing some ideas, and sharing some way forward.
Who owns and who has access to your electronic patient record? I've dated this because things change and it's important that we document the date that I have put together this presentation. I'd like to look at this as being your stool of happiness. And your happiness as a person depends on financial stability, good health, and family stability. And it's really important that you understand about how you are happy. And I thought I'd start with money. When you pay money into your bank account, who owns that money? Now, I would specifically like to ask Roger what he believes is the owner of that money. Roger is one of our audience. Can you just chip in, Roger?
Yep, sure. My answer to that would be that you own it. It's your money, and
Yep.
you have deposited it with a bank to look after, but that's all.
Yep. Yep. And that is exactly what I thought. And lo and behold, I discovered once you give it to the bank owns your money. I didn't know that. I suspect the majority of people in the UK don't know that. And I have obtained this by going to my trusted friend Gemini and asking Gemini to help me with this talk. So this is Gemini, but the evidence I've double-checked and I believe it to be correct. This is based on a fundamental legal principle established in English common law. Now, before I go any further, Roger, can you just confirm you can see the screen clearly for me, please?
Perfectly.
Fine. So here's how it actually works. And it's broken down to what happens to your cash and what you get in return and how you're protected. So when you give your money to the bank, you're a creditor. When you hand over your money, you're giving them an unsecured loan. The bank's right is they're legal owners of the cash. They put it into their general pool of funds and they use it to make money by lending it out to other people with mortgages, personal loans, or investments. You no longer own the physical or digital cash itself. Instead, you own a choice in action. A legal right to demand that your bank pays you back an equivalent amount of money whenever you ask for it, subject to your account's terms. So the practical reality, legal versus beneficial ownership. While the bank owns the cash, the law heavily protects your access to it. And this is managed through two concepts. Legal ownership, the person whose name is on the account is the legal owner of the account. They have the contractual right to instruct the bank to move, withdraw, or spend the funds. Beneficial ownership, the real owner, and this is the person who's actually entitled to the financial benefit of the money. In a standard personal account, you as an adult are both the legal and beneficial owner. However, in a trust, it changes. And you may well have set up a trust for your child or one of your relatives who may have impairments. And the trustee may be the legal owner, but the child or the true beneficiary is the beneficial owner. So at that stage, I'm going to stop and we'll have a short discussion about that because that does have a relevance to what we're going to cover shortly. So can I open the discussion and deal with any questions there are at this point? David, can you
Yes,
take over?
thanks, Angus. That was an interesting introduction to this topic. Are there anybody that's from Mark? Would you like to talk to that one, or do you want me to read it out for you?
I could speak at it. I mean, it's a great analogy, Roger. I mean, about the where the bank is holding your specific allocation of money that you have placed on deposit with the bank. And it's not manifested in physical currency or bullion or anything of, of hard value. It is a line of code that is held on the bank servers or in their repository somewhere, and it does have your name on it. Now, with that, and it has to be surrendered upon your demand. And that's the arrangement. But what happens if your demand happens at 2 a.m. at night and you need more than you can pull out of a ATM machine or anything like that? Again, you do have limitations that can the bank actually fulfill that duty, and that's during a certain set hours or whatever. It's very similar to your medical records. They are held in trust for your benefit and for
Mark, I'm going to stop you there because you're taking over my second talk.
Oh, sorry.
Any other
If I
points?
may, Angus,
yeah.
From my understanding, a bank, if you deposit a pound into the bank, now this is I think it's, correct me if I'm wrong, anybody online, the fiat is the ability for the bank to lend that out. They can lend, it used to be 7 times. I think from my memory in Australia, it went to 13 times. So they could lend out your $1 13 times via mortgages and so on, even though they only had $1 as a deposit from you. And that's when you have the run on the banks, as occurred in a couple of countries in Europe in the last few years.
And
Any other
before,
comments before we ask Angus to carry on?
Attila's got his hand up.
Oh, Attila, yep.
I in the previous session, Mark mentioned something, something interesting. Mark, if you want to repeat that ownership is 9/10 of the law, or just make that
Attila,
a bit more sense.
Can we come back to that in the second session? Because that's actually directly relevant. Now, those of you who will understand that I've been rather crafty because I've introduced the talk about health information by talking about money. But it's actually a parallel, and I had not realized that before I prepared this talk. So we're going back on to sharing this. Who actually owns the information that has been entered into my electronic patient record? And this is a question that is being asked more and more in 2026. And a lot of people get surprised because there is a separation of the physical data file from the information inside it. Believe it or not, the healthcare provider owns the physical record. The organization that creates and maintains the record, that may be your GP practice, your hospital trust, your medical clinic, is the legal owner of the physical or digital file, database, and infrastructure. So they own everything. That means the NHS in the UK, when you go into an NHS hospital, a record that is created is going into their record that they own. Under the data protection laws in the UK and Europe, the hospital or NHS act as the data controller, and they have a legal obligation to securely hold, maintain, and manage that file. And they cannot simply hand over or destroy the original database. They must keep it. The strength of this is much stronger than applies to our MPs who seem to have been able to lose their WhatsApp messages. In the NHS, if they were to destroy a case file, that is breaking the law. Now, what are your rights to the information that is now in their database? Well, you don't own the digital ink or the server that it's hosted on. You own the rights to the data itself, because it is your personal and sensitive health data. You do hold ultimate control over how it is accessed and used. I'm going to say that again. You do hold ultimate control over how it is accessed and used. Only you can decide how your personal medical information is used. You have a legal right to view and receive a complete copy of your medical records at any time, usually free of charge in the UK, via a subject access request or a patient portal. That is in place at the present time. Any of you who have tried to do that will have either found it very easy or very difficult. It's supposed to have been set up by NHS England, but in many areas, they haven't set it up properly, and you cannot easily get access to it. The right to accuracy is really important. If an error is made, such as an incorrect diagnosis or mistyped medication, you have the right to have it corrected or a note of dispute appended. Now, we have personal experience of this because my wife, who is a very nice lady, according to her GP records, has been in a mental care home for 2 years and has had a breast cancer, neither of which she had. And this occurred because the GPs have a system where they integrate in Nottingham, and all the GP practices have access to all the patients in the GP group. And one patient happens to have the same name as my wife. And her records were entered into my wife's record. And it took her 6 months to have it corrected and to have a note of dispute appended. And she got a copy of her file again, and she still found errors in it. So although you have the right, the mechanism to do that is not smooth within the UK. Control over sharing. Healthcare providers cannot sell or share your personally identifiable data with third parties, like insurance companies or commercial tech firms, for non-care purposes without your explicit consent. Now, you will have found, if you're in the UK, that you will quite commonly be asked if, because you are going on to a particular treatment, they can use your non-identifiable data to help with research. I strongly support that, but it must be non-identifiable data. Because in your file, there is lots of information which you would not want anyone else to know about. It may be that you've got a past history of being an alcoholic and having chronic liver disease. It may be that you've been pregnant and had a miscarriage. I inadvertently got involved in a case where I was asked to look at a friend's daughter's shoulder. They got the x-rays on a disc from the hospital, and it became clear when I opened the information on that disc that she had had a miscarriage or a termination. And I shouldn't have been given access to that information. And the problem is, it's quite difficult to partition information so that only the appropriate people get access to it. Now, you may feel that in the light of this talk, you want the hospital to delete your medical record, you want the GP to delete your medical record. You can't, because in the UK, medical records are legal documents used to track clinical decisions and to protect public health. In the light of what's going on in Nottingham with both murders and problems with maternity, this is a real issue. You generally do not have the right to erasure, the right to be forgotten for your medical history. The NHS and other healthcare systems are legally mandated to retain these records for set periods, and that's often 10 years, to ensure continuity of care. So in summary, the doctor or hospital owns the digital filing cabinet, but the personal story written inside belongs to you. So at that point, I'm going to come out, David's going to take over, and we're going to have a discussion, because I'm sure that some of you are absolutely shattered about that situation. I had no idea that it was like that. If you've got any
Mark,
questions.
I believe you got your hand up, Mark.
I did. Yeah, it's an interesting thing when you're dealing with digital data, because especially health data, because it is the patient's body data. But it's also the output and work product of a lab or a provider, and they have a valid claim of ownership to that same data set as well. The differentiator is who holds it. So ownership is one thing, but ownership, your health records are not your own personal property, exclusive property. They're held in trust, but they're also combined with others, other outputs that others have a valid ownership claim as well. So that's where it gets tricky.
Roger, your thoughts?
Yeah, it's very, it's fascinating. I confess that I did know that. And the reason I know it is because for getting on for 15 or more years, I was an investor and chairman of a company that did all the data migration for most of the EHRs in the UK. So we had to be very, very mindful of how we handled it, who had the responsibilities, and we had such. I won't mention the hospitals or the trust concerned, but we had situations where we were doing one very large migration into a new EHR, and we heralded to the trust's staff that they were letting us, or they were asking us to see data that we shouldn't see. And they said, don't worry about it. We just carry on. And we refused to. The second thing is that we were doing another data migration in a children's hospital. And really coming back to Angus's point regarding his wife, is this was two children, they were siblings, a boy and a girl. And the boy was perfectly fine, mostly. The girl had quite serious issues. And the hospital had combined the record. So when we saw it, okay, we were able to identify the fact that this had happened and pass it back to the trust to say, you need to sort this out. And the third point I want to make is that having had all that time, the quality of data that's held in electronic record systems in the NHS is far from perfect. It's full of errors. It's full of duplications. It's full of I'm just trying to think how to express it. What's happened is that users have found that if there's no convenient place in which to put a piece of information, and for example, there is a dental record, they'll put it in there, and that becomes used. So you find all these things. And the last thing I want to say, which is really the more important thing for me, is the government has apparently endorsed that Palantir as the provider of the federated.
Roger, I'm going to stop you there because that's going to be discussed next.
Okay, I'll stop because it's my big concern.
Yeah. Okay. Now, okay. I would like, he hasn't put his hand up, and I hoped he would put his hand up. We have a member of the audience who has been responsible for the records in general practice and the London care record, who knows all the pitfalls. And Phil, are you able to say anything, or are you going to keep your mouth shut?
No, I'm very, very happy to comment. Can you hear me okay? I'm on a mobile device. Yeah. And I think, yeah, basically, what the way you've described it, is, is correct. There's a lot of confusion over who owns the record, whose responsibilities, and I think we probably need to split ownership from responsibility and ability to access. I've been involved in giving patients access to their records at a national level, and I think we are now moving into a world where it's generally accepted that even though the GP who writes the record may be the data controller and the owner, the patient has the right to view that record in most circumstances, and there are some very careful exceptions to that where safeguarding's involved or where the patient may come to harm. But happy to comment during the rest of the meeting as we go through.
Thank you very much, Phil. David.
Thanks, Phil. Angus, would you like to move on to your third section?
Yeah. Right. In the UK, we have an Official Secrets Act, and it's a very important act. And I knew somebody who I think worked at Bletchley, although she would never admit it, who was sworn to the Official Secrets Act. And it's fascinating how firmly she adhered to the rules. The UK Health Secrets Act is something that I feel that the NHS England and the Department of Health and Social Care believe exists. It does not exist. We are moving into an era of openness, and we have to just accept that. And I'm going to talk now about who has access to your electronic patient record, because that has been high profile over the last 3 months for various reasons. If you go into an NHS hospital, hospital staff can access your electronic medical record using their NHS smart card, which is a primary key set used by health professionals, doctors, nurses, physiotherapists, etc., to access your medical data. It's a standard plastic ID badge, but it's got a chip and pin, and they use it in exactly the same way as a bank card. In order to access the computers, each individual is supposed to put in their card, and that labels them as the person using that computer and accessing all records through a data tracking mechanism within the software. There have been huge problems in NHS hospitals because of the computer hardware. Much of the hardware is old, and it can take anything between 2 minutes and 10 minutes for people to remove their card and for the next person to put their card in and get access to the computer. And so in the past, a lot of people have been prepared to use each other's ID badge because it's plugged into the computer and it saves them time. They're not allowed to do that, but in order to do their work, they almost feel they're being pushed into doing that. Depending on the NHS facility, NHS hospitals or emergency care centres or GPs, the level of access that is, who is allowed access, may be restricted. However, it is difficult to predict who should be restricted, as so many team members need access. As a consequence, my understanding is that the medical notes are not properly partitioned in a way that limits access to some personnel compared with others. Now, Phil Cozanne will know the answer to that, and I'm keen for him to tell us about it in the discussion. So, the smart card system works in this way. Whenever a doctor, nurse, or pharmacist wants to look at your medical history, prescriptions, or test results on an NHS computer, they cannot simply type in a generic username and password. There is a strict physical process. They've got to put their card in the slot. They've got to use their chip and PIN. They have a 6 to 8 digit passcode, which only they should know. And we know that that rule is broken by a number of consultants who give their passcode to their secretaries. There is a role-based access. The card identifies the national digital identity. The system checks their job title. The GP will see the full clinical notes. The pharmacist will see medications and allergies, and the receptionist might only see appointment scheduling screens, but I am not sure how good that partitioning is. And as I said, staff are banned from sharing cards or keeping them in the machine when they walk away. Leaving a smart card unattended in a computer is a serious disciplinary offence for which you can be sacked. Although the hospitals have been reluctant to do this in the past, that has suddenly changed, and I'll explain why. In the Nottingham hospitals, we admitted a number of people who died and were injured as a result of a murderer. 2 years after the event, the NHS Trust confirmed that 150 members of staff had accessed the records of those patients who had died. It was claimed that most were for legitimate reasons, and I totally accept that. However, some were not. Some were simply nosy, wanted to know what the injuries were, and looked at patients' notes they should never have been looking at. There has been an investigation. 11 members of staff have been sacked. 12 have received final written warnings, and 2 a first written warning for accessing records inappropriately. That is why the situation has now changed. In Southport, a man, that is in England, a man murdered 3 young girls and attempted to murder 10 others at a Taylor Swift-themed dance class. It has now been reported that inappropriate access to entry hospital records about Southport patients was identified for 48 Liverpool hospital staff. Hospital action on this is in progress. Now, it's not just minor breaches that have taken place. Bedfordshire hospitals, through their pathology system, had an online attack, and 33,000 of its patients had personal data stolen and published online following a major Synovus ransomware cyber attack 2 years ago. The NHS Federated Data Platform has been taken over by Palantir. The plan was that it safely connects information across the NHS. In other words, everybody's data goes on to the Federated Data Platform, making it easier for staff and clinicians to do their job. This has been carried out by an American company called Palantir, and there are a number of controversies over that, but the main one is, at the moment, is that Palantir staff have been able to access non-anonymized patient information. Now, these are staff that are not under control of the NHS or the UK government. These are staff outside our country. And we are aware that for American companies, the President of the United States can clearly dictate that they have to release any data they have at his request. And this is a real concern for companies in the United States who believe their confidential information is truly confidential, but at present are feeling very insecure. Now, I've talked a little bit about the negatives, but I do want to talk about the positives. The COVID pandemic resulted in relaxation of strict NHS regulations. Before COVID, WhatsApp was not approved at all for any clinician in the NHS to use. However, when COVID broke, it was approved for clinical use as long as patient identifiable information was not transmitted in WhatsApp messages. That transformed patient care during COVID. At the same time, the rules regarding access to patient data were relaxed, and Oxford University and Ben Goldacre were able to carry out some fantastic research on data they would not have had access to before COVID because of the relaxation of the rules. The COVID pandemic highlighted how much the NHS was being held back by the NHS and UK regulatory rules. This research carried out during COVID did involve some risk-taking. Unfortunately, the NHS has gone back to being very risk-averse, and this is having a negative effect on today's research. In my conclusions, the audit trail and gateways for access to patients' information must be improved. I was very surprised at the delays in Nottingham and Southport over when they realised that there had been inappropriate access to patients' records. And that ought to have been set up with the audit trail involved in the development of the software. I believe the NHS regulatory processes need to be revised if the NHS is going to improve its services. At the moment, our research is being stifled too much, and that is because the NHS is too risk averse. This is the final discussion. And we will end after this discussion. Thank you very much.
Thanks, Angus. I think very thought-provoking there. Let's open it up. Let's get the interest of anybody online who'd like to make a comment, some thoughts, some recommendations, some ideas. Go on, Roger.
I'll have a go. I mean, that was a fantastic view, Angus. Absolutely excellent. It's a question of where to start. I mean, yes, I am very concerned about Palantir, but for the reason that you identified, is that the government has given access to Palantir staff to have access to the records. And that seems to contravene absolutely the regulations as they stand. It also means that by that very action, once you open a door, even slightly, okay, people start pushing through it and it opens up. And I think to close it is going to be very difficult. And I agree with you in terms of the NHS culture of being risk averse. It is too risk averse. It inhibits innovation. It inhibits research. I mean, I was talking with a clinician this morning for 2 hours, and that was one of the issues, is how long it just takes to get through the bureaucracy and the various levels in order to get something approved. So I come from a background of 20 years of implementing and designing and building and running companies that implemented EHRs. And when we started in 1980, which was a joint venture with an American company called Shared Medical Systems, which is now part of Cerner Oracle. I'm not sure any of that original software exists, is we tried to take an American system for the NHS and we abandoned it. And what we did from a European point of view was to build a completely new product that was suitable for European distribution and implementation, but adopted the American concepts. I mean, the structure was fine. It was just the way it worked. And one of those things was role-based access.
Yeah.
We were very, very strong on trying to identify that every individual had a role. And the fact that you had 2 nurses, shall we say, or 2 clerks who appeared to have, the same level, depending on what they were doing, they would have different access regulations. It wasn't simply you give it to a nurse on grade X, okay, and they all have it. It's hard, but my worry is it's become too open, and I don't think politicians understand at all just what they've done.
Can I just check with Phil? Because Phil, I spent 2 days putting that together, and I don't know whether it's right, but I suspect you have a pretty good idea as to how accurate what I have said is and whether I've made mistakes. And if I've made mistakes, we should actually make them public now.
So I'm not sure there's necessarily mistakes there, but it's understanding what the practicalities are and what the balances are between access and people's ability to do the job. So certainly the delays on login, etc., often down to to poor investment in IT, old hardware as you mentioned, but that's changing. I think the interesting one is the access controls, because I was certainly involved in a project where a GP system was locked down so tightly that people couldn't actually do their work. And I think there's a balance between technical controls, so how do we stop person X getting access to information, and professional controls. So as a GP, I might have access to information that is it wouldn't be appropriate for me to access, and it's down to my professional accountability not to go looking at that information if it's there. So I think we underplay the professional controls quite a bit, and also certainly within general practice, if our admin team didn't have access to patient information, weren't able to scan records, give patients results, etc., that we would very quickly grind to a halt. But in that situation, they're working under our supervision, under our control, and under the strict governance rules that we place upon them. So I think for each point you made, there is a counter argument. The bit about data and access to data. As a GP, if I share data and it's used inappropriately, I'm personally liable as data controller for that information and how it's governed. So there's a lot of challenges around liability, some of which have been addressed in the new NHS bill. So I think a lot of what you've spoken about is, or at least has been, correct until recently, but is rapidly changing as we move on with the IT developments, and probably more importantly the transparency and openness as far as giving patients access to the records. I'd like to see them having access to the audit trail so they can see who's accessed information and why, and that's a journey that we're starting on.
If I may, Attila, I'll get to you in a moment, and also you, Mark. I want to reflect on two comments made in the Mark. You said something earlier on, which actually comes in on something you just said. Then, Phil, there's policy and there's practice. These two are not always the same. Those at the forefront of dealing with patients and the stress levels and within hospitals or wherever the providers are working, it's pretty high pressure.
There's what we say we do, and then there's what we actually do.
Yes, well put, Mark. And the other one is by Rajiv. If you can just make a comment, and just very quickly on this, your comment with regards AI, if you take the person out of it and you're looking at the data purely from a clinical perspective, AI has potentially got a nice role to play here. Would you like to comment, Rajiv?
You're muted, Rajiv. Can you unmute?
Yeah, thank you, David, and thank you, Angus, for pointing out. I've been engaged in developing models for getting better, I would say, modules for the doctors to do better decision-making systems, in fact. And luckily, I mean, we have our own chain of clinics, and we have the data access directly to a private clinic, not here in the UK. We are out of the UK. We own those clinics. But I have had a long discussion with my teams. In fact, we have come up with something called anonymized data, in a way that if we have, let's say, some diseases occurred and some treatment was given, I don't need the name of the person, and my AI can actually separate both of them, run through that. I just need the data of how many numbers were given, what was actually asked, what questions were being asked, rather than knowing the person. So we have easily were able to separate these data from the person, and we have created a kind of a shield towards it that nobody can use it. The GP can only use it if he wants to use and attach the data, but it will help the decision making. We were finding a lot of issues and even talking about to NHS and to people around, because they feel when they share the data, the personal data goes away. But it's not the case with the new technology. It's not required. So I'm not sure whether NHS would like to have a look at this kind of options which are available now around the world. Yeah.
Rajiv, we had a
Okay.
very good presentation during COVID by Ben Goldacre, in which he highlighted how difficult it is to anonymize data. For instance, if you have a female aged 30, height 4 foot 4 inches, occupation actress, I can tell you exactly who that person is from these 3 bits of information because she's on television, she's on one of the TV programs, and if you have clever IA that can separate it, I have no doubt we're going to have clever AI that can put it together again. So that I think there's a real issue about how we make people's information not anonymized. We have to strive to do it, but it's difficult.
Yes, Dr.
Thanks.
Angus. Yeah, Dr. Angus, because that's what the plan is. In 2021, when I was doing, things were not there. But with the latest technology in the last couple of months, in fact, things have really come up very well, and we were able to showcase to the other governments, and they were very open to discuss. In fact, that's the first point first, in fact, and then we were able to show them they don't need to see. I don't need to see who the person is, especially in a domain like dermatology where I'm working on. I don't need to see the person, right? I don't need to know. I only want to see a lesion. Whose lesion I don't really care about it. My AI cares about only, and we were easily able to, whenever, let's say, you scan and send it back to me, it will automatically separate from the personal. The AI works in such a way, actually.
Again, Rajiv, I would challenge you. If that lesion has a tattoo adjacent to it, your anonymization may be damaged.
Okay, let's leave that debate for another session.
Yeah, so it's a debate. Yes.
Thanks, Rajiv. Attila, one last comment.
I don't have a comment. I'm just blown away by the level of conversation. I have a question. Actually more of a mission, especially to Phil and Roger, as both are data savvy and understand how DHRs are working. Now, my mission to you and my proposition to you is, what would be the best practice that would give an individual the ability to port their data like they port their mobile phone, that allows them to integrate with any ecosystem? You know, UK, it's trust, it's segregated, and every single time you attend a clinician, you have to reshare your information every single time, which means that a lot of information is lost in the same process because of the stress. So what would be the best practice in your point of view? If somebody wants to build AI, aka me, a best system, please advise.
I mean, I think what
let me bring in Mark on this one. I'll give Phil and Roger a rest. Mark?
So, Attila, that is precisely what I'm building right now, is applying property rights theory to when it comes to digital data, something intangible. Property rights theory hasn't really caught up with the rest of the world, but I would say ownership is subordinate to custody when it comes to health data. And right now, the patient has not had the ability to receive data should they request it from the NHS or any provider. Has another way to receive it, organize it, or meaningfully share it. And when I say meaningfully shared, that they can plug into, with technical parity, the same data sharing ecosystem, and that whatever data they share is acknowledged to have the same confidence as the type of data they receive directly from a provider. And that does not exist right now. And we've seen something similar with these personal health faults with Apple and Viva, Palantir's even done it to where it's you can have a measure of control over your data. The problem is clinicians do not view that as reliable. It's broken a chain of trust when it comes to the provenance because you, the patient, are not clinically verified. You're not licensed and so forth. So that's really why those have failed. But those never connected into the ecosystem. And so to have this portability, you have to have custody, of course. So you need a store and share capability, but you also need to be able to carry it with you and at any encounter to be able to plug it into any clinician that you need to share it with. And that what you share with them, they view as the same as had they gotten it from an upstream hospital.
Thanks, Mark. Phil, you've got the floor. You've got the last comment.
I think it comes down to probably one word that Mark actually mentioned, which is trust. Yeah, we've got to have trust in the system. Yeah, that patients will. Yeah, I think giving more control to patients, greater transparency, but it comes down to to trust on all parts, and maybe just leave it at that given the time.
Yeah, here. That's a fabulous way to end the webinar. It's all about trust.
Before we finish, can I just announce that next Wednesday's webinar is going to focus on whether what is the best for you to use, ChatGPT, Gemini, or we've got 6 options. And we have a speaker who is very knowledgeable, has done a study on these, Peter, who's going to tell us which one is best for us to use and for what. So you're very welcome to come back at 7:30 p.m. British Summer Time next week to listen to him.
Thanks, Angus. You always get the last comment. Thank you very much, everybody, for dialing in and listening. The comments on the side, some of the comments that were placed on chat. I'm sorry I didn't get to you all, but thank you very much. UKDHC is a not-for-profit organization. It's member-based. If you want to become a member, have a look at the website, and it'd be lovely to have you part of the team. Thank you very, very much.